Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
All right, let's dive deep into the pharmacology of glomerular diseases. We're going to break down the key drug classes, how they work, and the clinical strategies you absolutely need to know for your exams, focusing specifically on nephrotic and nephritic syndromes. So here's our game plan for this explainer. We'll start by really nailing down the difference between nephrotic and nephritic syndromes. Then, we'll walk through the pharmacology of our main players, ACE inhibitors, corticosteroids, and other big gun immunosuppressants. Finally, we'll pull it all together into a solid management strategy and highlight the most important exam pearls you need to remember.
Okay, first things first, you can't understand the treatment until you understand the problem. The distinction between a nephrotic and a nephritic syndrome is everything. It dictates your entire therapeutic approach. So let's lock this in.
The easiest way to think about this is with a simple analogy. Think of nephrotic syndrome as a leaky filter. The damage here is subtle, messing up the specialized cells called podocytes. This makes the filter lose its ability to hold back protein, so you get massive protein leakage. On the other hand, nephritic syndrome is an inflamed filter. Here you have an aggressive immune attack causing actual physical breaks in the filter, which leads to blood and red blood cells spilling into the urine.
So, focusing on that leaky nephrotic syndrome, you see this predictable domino effect. It all starts with massive proteinuria, just tons of protein pouring into the urine. This, of course, depletes the albumin in the blood, leading to hypoalbuminemia. With low protein in the blood, the oncotic pressure drops, and fluid leaks out into the tissues, causing generalized edema. The liver sees this protein loss and panics, trying to make more of everything, including lipoproteins. This leads to hyperlipidemia, and you'll even see lipids spilling into the urine, which is called lipuria.
Now, when we say massive proteinuria, what does that actually mean? This is a number you absolutely have to memorize. The official diagnostic threshold for nephrotic range proteinuria is protein excretion greater than 3.5 grams per day. This is a classic exam question.
And as a direct result of losing all that protein, the albumin level in the blood tanks. Clinically, we define the resulting hypoalbuminemia as a serum albumin concentration below 3 grams per deciliter. It's a simple cause and effect that you need to connect.
Now let's switch over to the inflamed filter of nephritic syndrome. Here, the signs are all about inflammation and damage. The hallmark is hematuria, or blood in the urine, but the dead giveaway, the pathoconemonic sign, is finding red cell casts in the urine. That tells you the bleeding is coming from the glomerulus itself. All this inflammation also tanks the kidney's filtering ability, which leads to a buildup of waste products, low urine output, and hypertension.
Okay, with the pathophysiology established, let's talk treatment. The first-line drugs we use to fight proteinuria, no matter the cause, are the ACE inhibitors. Their whole job is to lower the damagingly high pressure inside the glomerulus. So, the drug class here is the angiotensin-converting enzyme inhibitors, or ACE inhibitors. For your exams, you'll want to know the prototypes, enalapril, captopril, and benazepril. Now remember, when a question mentions any one of these drugs, it's really testing your knowledge of the entire class, because they all share the exact same mechanism of action and side effect profile.
So how exactly do they work? It's all about the renin-angiotensin-aldosterone system. ACE inhibitors block the enzyme that converts angiotensin 1 into angiotensin 2. Now, angiotensin 2 is a super potent vasoconstrictor and has a special preference for squeezing the efferent arteriole, the vessel leaving the glomerulus. By blocking its production, you get vasodilation of that efferent arteriole. This opens up the exit, which dramatically lowers the pressure inside the glomerulus, and that's what reduces the amount of protein being forced out.
If you remember one thing about ACE inhibitors for your renal exams, let it be this. This is the exam pearl. They reduce intraglomerular pressure. This single hemodynamic effect is the key to their kidney protective power. By lowering that pressure, they directly ease the force pushing protein across that damaged filter.
So ACE inhibitors are great for the pressure problem, but they don't fix the underlying cause. If the problem is an immune system attack, we need to bring in drugs that can calm the immune system down. That's where corticosteroids come in. They are our primary immune modulators.
The main drug class we use for immune modulation is, of course, corticosteroids. The prototypes you'll see everywhere are prednisone and its active form, prednisolone. It's crucial to understand that we're not talking about small anti-inflammatory doses here. In glomerular disease, we use high doses to achieve powerful immunosuppression.
What's really interesting is that corticosteroids have a dual mechanism of action. You have the classic genomic action, where the steroid enters the cell nucleus and literally tells the DNA to stop producing pro-inflammatory genes. But at the high doses we use, they also have a non-genomic action. They can work more quickly and directly to stabilize the internal structure of the podocytes, helping to prevent further injury right at the source.
So, the reasons we use them flow directly from these mechanisms. We use steroids to suppress inflammation caused by antibodies, which in turn helps reduce proteinuria and stabilize overall kidney function. Generally, you'll see them prescribed for patients with proteinuria creeping up over 1 to 3 grams per day. That level of protein loss suggests an active immune process that probably won't go away on its own.
But what happens when steroids aren't enough, or the disease is just too aggressive? That's when we have to escalate therapy and bring in even more potent immunosuppressive agents. These are the next step in our treatment plan.
So here's a look at our immunosuppressive arsenal. These are generally our second-line agents. We have drugs like cyclophosphamide, anti-metabolites like mycophenolate and azathioprine, which stop immune cells from multiplying. And we even have advanced biologic agents like rituximab, which is a monoclonal antibody that specifically targets and eliminates B cells, the cells that make pathogenic antibodies.
Now, we don't use these drugs lightly. Their indication is very specific. They're for patients with progressive disease that isn't responding to steroids. The whole goal with these agents is to shut down the autoimmune process at its source by stopping the production of the very antibodies that are causing all the damage in the first place.
So, treating the kidney itself is absolutely critical, but we can't forget about all the systemic problems these syndromes cause. We also have to actively manage the consequences throughout the body with supportive therapies.
And this really takes a multi-pronged approach. For the massive edema, you need diuretics and a low-salt diet. For the sky-high cholesterol caused by the liver working overtime, you need statins. This next one is critical. Nephrotic syndrome puts patients at a very high risk for blood clots because they're peeing out their natural anticoagulant proteins, so they may need anticoagulants. And finally, they're also losing immunoglobulins in the urine, which increases the risk of infection, so we have to be extremely vigilant.
Okay, let's pull all these pieces together now into a cohesive strategy and really hammer home the most important exam pearls one last time. This table is pure gold for studying. Let's walk through it. For nephrotic syndrome, the headline is massive proteinuria. Remember that number, greater than 3.5 grams, and the low albumin that follows. Treatment is about managing the consequences. Diuretics for the edema and maybe steroids. Now look at nephritic syndrome. The key here is the urinalysis. You're looking for hematuria and those all-important red cell casts. The treatment focus here is much more aggressive. You're trying to control severe inflammation, often with potent immunosuppressants, and manage the dangerous hypertension that comes with it.
All right, here are the final high-yield takeaways. First, nephrotic is the leaky filter, defined by massive proteinuria over 3.5 grams a day. Second, nephritic is the inflamed filter, characterized by inflammation and hematuria. Third, ACE inhibitors are the foundation of treatment for proteinuria because they lower that damaging glomerular pressure. And finally, steroids and other immunosuppressants are how you target the underlying immune attack that's causing the problem.
So, to wrap it all up, let's put it into a clinical context. You have a patient with progressive nephritic syndrome. They're on high-dose steroids, but their kidney function, their eGFR, is still falling. Thinking about our treatment algorithm, what kind of therapy that directly suppresses antibody synthesis would be the logical next step? This question makes you integrate everything we've talked about, from disease progression to our tiered pharmacological approach.